So hi Tara.
Hi, John.
So we've decided to have a quick chat because a couple of weeks ago you had an inquiry by a mainstream media journalist, and you were going to go and have a chat with them. But then the daily news agenda changed, and it got stood down. So I thought actually, if there is interest, then as we've worked together for years and years and years on things like share care records and data sharing, it'd be helpful for us if we just had that discussion as if you went forward with that interview in the first place. Um, so do you want to just kind of fill us in on what the original request was for?
Yes, so this came about because of the announcement of the single patient record, and it's really interesting because this is something that's so important to us and the work that we do on a day-to-day basis, and it builds on the foundations of things we've been working on for years. But to see it take such a high agenda now and come into the public interest, as it were, and I think there's a number of different reasons for that. I mean, obviously, there's the benefits that have been mooted from the single patient record, and we see some really big numbers. So that's clearly very interesting. But there's also concerns about this as well. So, not just looking at the benefits and what that's going to mean for patients, but also thinking about the appropriate use of data, the uses of that data, and the role of patients in this whole process. So yes, it was really to look at the opportunities from the single patient record, have a think about some of the risks and some of the areas that we collectively need to think about, and how we really ensure engagements as we go through this program of work and ensure that it delivers the benefits that we've all been discussing for a while now.
Indeed, and I suspect one of the advantages that we've got over the original chat is that we'll be happy to share everything.
Yes,
So,
yes,
so,
yeah,
so
absolutely.
yeah, so we'll share this chat, and it's important that whilst we have history delivering projects, and whilst we kind of got our formal backgrounds on, this is just having a chat about the work that
Yes.
we do, and actually
Mm.
work that really interests us going forward.
Yeah, yeah, absolutely.
Indeed. So obviously, do you want to just tell people about your history with kind of share care records?
Yes, absolutely. So I worked for probably about 6 years on the shared care record program alongside yourself, John. So you were our SRO for that program. And we were focused on rolling out the Yorkshire and Humber Care Record across different health and care settings in the Humber and North Yorkshire region. And we were also looking at care planning as well. So we rolled out the end of life solution. So we'd really identified this through engagement with our clinical stakeholders and operational stakeholders in different organisations. And this was a real pinch point. And I think, working together over that period of time as part of a broader team of people, we had, experts from different organisations, a real blended team approach. We really started to understand some of the challenges around shared care record development and deployments, particularly around things like benefit realization and how organizations and people work together, the importance of really founding this on a basis of business change and clinical engagement rather than treating it as a digital program, and the importance of that team approach that came from this from multiple different stakeholders. So my involvement in the program was one of the joint delivery leads, reporting into you as our SRO, and we were responsible for the prioritization of the roadmap, engaging with stakeholders, and the actual implementation, and really importantly, the benefit realization as well, which is, ultimately the reason why we're all getting up out of bed in the morning and doing this.
Indeed. And it feels a long time ago now, but do you remember what the world was like before we had share care records, before we
Mm,
had the clinical system local sharing agreements which we had
mm.
in place? And you can,
Yes, yeah,
as we often talk to patients, and we had something called Simon's story, which was a real patient
yes,
story,
yeah.
which we often
Mm,
reflected on.
mm.
But can you just reflect back on how fragmented everything was back then?
Yes, yeah, absolutely. I mean, I think there are a number of different ways to look at this, but I'm going to start with the patient side of things because I think this is a common thread that we need to, it's run through all of our programs, but it will also need to be quite, at the forefront in terms of future developments around programs such as the single patient record or around neighbourhoods. And ultimately, what it meant for the patient was that they had information about themselves held in lots of different systems. And there was basically no or very little communication between those two systems or multiple systems. From a patient experience perspective, that meant there was a lot of repetition in terms of repeating information about their current health, medications that they were on, and of course, all of the dangers around forgetting things, and also the frustrations as well around that. Um, but ultimately, I think there was an expectation from patients that information was being shared, but a frustration that that wasn't happening. I mean, if I give the example of the end of life
Mm,
care pathway, that's a really good one because it's something that I think most people feel very strongly about. It's probably the most difficult pathway at a person's individual, whether it's you yourself or whether it's a family member or someone that you care about. And what we were seeing in that situation was that often patients would be sharing their preferences about where they wanted to die, the circumstances under which they wanted to be admitted to hospital, what they did and what they didn't want to be happening, whether they wanted CPR to be attempted, for example. And of course, at that time, as things progress, they might be changing their minds about that for very good reasons. But often what that would result in would be different versions of the truth being held within different organizational systems and not sharing information between that. So we're going quite a long way beyond frustration at this point. We're talking about an incredibly difficult time for people and really important information about their care and their wishes not being shared. Now, of course, that was a technical problem because we didn't have that interoperability between different systems, but it was also a process issue as well. So we didn't have the processes in place to enable that data sharing and how to act on that information when you receive it. And we see that across lots of different pathways, but also in terms of other systems and experiences as well. And one of the things I know that you were always really keen on, quite rightly, was to bake in the patient representation and also the carer representation within all of the digital programs that you did. And I think what was the real eye opener for me was listening to those experiences of people. I mean, you've mentioned Simon's story, and this is a really important case in point where you're looking at people with complex needs and they're coming into contact with lots of different parts of the health and care system. Often the coalface of that care delivery is going to be outside of big organizations, so organizations who aren't particularly digitally mature. Um, and we're talking about patients, but all of these patients are people ultimately. And I think, when we look at it, so, coming back from interoperability and data and taking it back to the patient and the carer and their experience, it was very fragmented. There was a lots of repetition and frustration, but also just the deep impact that could potentially have on individuals.
did I think I've still got a link to the YouTube version of Simon's story. So
Yeah.
as part of the notes which we
Mm,
kind of put out there, I'll make sure that we
mm,
include a link to that so people
mm,
can just get the context. It was a
yeah.
very, very complex patient, Simon was.
Mm,
And one of the things he came to us and said was, I have to tell my story each and every time I see a
mm,
member of kind of
mm,
of my care.
mm,
And sometimes it's duplicated, but also people don't understand my abilities and my understanding of my
mm,
requirements. And nobody ever
mm,
asks me. It's always the questions
mm,
always goes to my PA or
mm,
to my wife because people don't
mm,
understand don't understand. So actually that ability to recognize and support that
mm,
we've all got one story,
mm,
we should only ever have to tell it once and then add
mm,
additions onto it as
mm.
our process changes is kind of
Yes. Yeah.
really, really important
Mm,
to me. You know,
mm,
and you kind of touched there, on it being broader than just an IT solution. There was
mm,
some really significant fundamental process change across
mm,
entire systems, which
mm,
allowed
mm.
some of that success to kind of
Yes.
happen.
Yes.
This was a great example where you cannot just deploy a solution onto someone's computer
Mm,
and it have an impact, because actually if we did that, there wouldn't have been
mm.
any benefit at all. Um,
Absolutely.
but it involved all the organisations in that in end of life care coming together, working on agreed pathways, agreed processes, and then implementing the change which was supported by the digital tool,
Yes.
which we
Mm,
enabled, and then by linking that into as many systems via the shared care record as
mm.
possible, we did
Yeah.
see some real we did see some real benefits. And the amazing Rochelle has recently published our latest benefits article on that.
Mm.
And you can see that in just in terms of end of life and saved conveyances, we're actually over 5,000 over the last 12 months, which is a tremendous achievement.
It is.
It is,
Mm,
and and we kind of see headlines at the moment where NHS have set requirements for 20,000 A&E visits a year to be saved. Well, just on end of life visits alone, just
mm,
our part of the world is kind of a
mm.
quarter way there.
Yes.
So
Yeah.
so if we all come together, we've
Mm,
got some evidence there that
mm,
however that metric was formed, we can
mm.
evidence that we can achieve that and so much more.
Absolutely. Yeah.
And that's something really kind of fundamental. The work that we're doing on shared care records at the
Mm,
moment
mm,
should be a really good, strong evidence base that some of
mm.
the future ambitions are not only possible, but really, really achievable.
Yes, yes, I couldn't agree more, John. And I think your points about this not being about digital is absolutely fundamental. So yes, we need the technology to underpin this, and we need it to, to enable the interoperability and to share data in a safe and secure way, because obviously, we need to mitigate against any potential risks here. But ultimately, digital systems don't drive change, people drive change. And it's the processes, it's the things that we can do differently because of technology. So it's very much leading from where do we want to get to? What processes do we need to actually change in order to do that? And then working backwards from that, from what data and digital need to do to enable to support that. And I think, I reflect on the approach that was taken. So I've talked a little bit about the approach that you took from your sort of digital strategy perspective and your engagement perspective. And you brought together stakeholders from across the health and care system. And I think that's really, really important. But you also had those patient and carer representatives in there as well to keep us honest and hold us to account. But also in terms of the way that you structured the programs that we were delivering as well. So again, thinking about the end of life program, the first thing that we did, before we even started looking at technology, was to convene a clinical design authority. And we had a broad representation from across different stakeholder organisations with strong clinical leadership. We got together, and it was difficult because all users are different, care settings are different, people have different preferences, different levels of data that they might want to be sharing. But you enabled that in a collaborative way. And with that clinical leadership absolutely baked in and digital working alongside that, alongside and in partnership with suppliers as well. So we didn't have a combative approach. We had a partnership approach that was focused on shared outcomes. And I think baking that in right at the outset, so thinking about the problems we want to solve and using digital and technology and data to help us solve that, was absolutely the reason that we could get to that end result that you've talked about. So, thinking about things like reduce conveyances, thinking about avoidable admissions. And if again we bring that back to the patient, these aren't just numbers, though of course it has a system-wide benefit. Each of those numbers represents an individual patient and their family. as well. So I think, thinking about the benefits, we can't put a number on that. Of course we can't. But if we remember that each of those numbers is an individual and their family, I think that really, really sort of contextualizes what we're trying to do with productivity, and those other benefits being a byproduct of that.
Absolutely. And there was some stuff happening which should never happen, things like duplicate tests as well, which is just terrible.
Absolutely.
Okay. So we've talked about some of the things which worked really well. Okay.
Mm.
What were some of the things that didn't work well?
Yeah. So I think our initial focus on benefits. So when we first started this, we were thinking about it from a very outcomes based perspective, from a very high level perspective. And ultimately, I think the NHS is really good at this, and this is baked into things like business cases. We think about the benefits we want to achieve, but frequently we don't think about how we're going to measure those going forwards. And, ultimately, that's the only reason we're doing this. We're not doing benefits to try and get a business case to be approved. What we're doing is trying to give value to taxpayers and benefits to patients and the population, and to the people who are working in the NHS as well. So I think, once we started thinking about things from where the business change was, and where the use cases were, I think we really started to really accelerate what we were capable of doing in terms of benefits. I think also linked to that, from a benefits realization perspective, sometimes we can think about it, in terms of a silo. But ultimately, benefits realization is just one part of the digital transformation process, or the overall transformation process. And often benefits don't perform. And I think, ultimately we learned through the process that when benefits aren't performing, we needed to bake that into business change and adoption, whether it was looking at how we were making the system available in terms of its usability, whether we were thinking about training, whether we were thinking about the types of system and data that we were making available at what points in the process, or whether we were thinking about the user experience. And, I think that, we in the digital world often talk about closed loop, but, and we might think about it in terms of things like prescribing, for example. But I think in this case, it was very much around closing the loop in terms of benefit realization. I think also recognizing that, if you're going to get people to change the way that they do things, because, ultimately we're talking about clinical and operational and admin people who are incredibly busy. And ultimately, if you're going to ask them to change the way they do things, you have to deliver benefits from day one. So I think one of the learnings that we really got from this was understanding what the most important information was that we needed to share to different health and care contexts, and to prioritize that. Bearing in mind that most of our stakeholders were not starting from a blank sheet of paper here. We had lots of stakeholders who were already benefiting from some great, quite tactical interoperability between different systems. So I think about things like SLIP, when you were making information and data available between EMIS and System 1 practices. So we had quite a high bar that we needed to achieve to deliver value to certain stakeholders. So at some point in the process, and I remember this clearly, we did a lot of work with stakeholders and different segments of the health and care population in terms of identifying what data they needed as a core minimum data set to deliver value, and then link that into the benefits. And I would really, I guess, retrospectively, think about, baking that in perhaps earlier, and, really prioritizing the use cases and the work that's done, and the data and interoperability work based on that sort of core minimum data set, and then building on that over time.
Indeed. So you need to understand the gaps. Okay.
Mm.
You need to be able to evidence the benefits. You
mm,
probably need to make sure that you've got clinical engagement and service use engagement, so that
mm,
we've got that subject matter expert, so we can understand what it is that we're trying to achieve. You can't do that if you've got poor data quality, because poor data quality is the enemy of kind of shared care
mm,
records. And you need to make sure that there are owners in place who can take responsibility for the delivery of
mm.
each of those um, benefits. And it's not all about the technology, is it? There's kind of a lot
It's
there
not.
to pick up and kind of
Mm,
run with, really.
yeah.
But that clinical engagement, that data quality, owning benefits. If you don't get all that in place, then we're never going to get to that question. What's my favorite question? So what?
Yeah.
You know,
Yeah.
if you can't
Absolutely.
if you can't answer that question, then you've got to really think about why you're doing what you
Yes.
what what you
Yeah.
what you're doing. So there was obviously stuff we were doing well. There was some stuff where we had to learn some real lessons. It would be such a shame as we move from share care records to single patient records if people had to learn those all over
Oh,
again, which is one of the
absolutely.
reasons why we're trying to do something like this. Um, but there is, I guess, rightly a lot of concern nationally at the moment around data security and, importantly, the trust that the public have in it. Okay,
Mm,
so without getting into too much of the politics, obviously Palantir are
mm,
currently in the
mm,
headlines. There's
mm.
currently ongoing GP collective action, which it's focused around the eroded public trust in data security. Um, Going back to how we first started some of this, how did we get assurance that what we were doing was safe?
Yeah. So, I mean, I think there's a couple of different issues here. So we can think about the security of the data from a cyber perspective, but then there's the public trust piece. So I'll start with the second piece first. So the overarching Yorkshire and Humber Care Record programme, or Interweave, as it's now, because it's now available more broadly, it was really underpinned by a fantastic piece of work that the YHCR did right at the beginning of this, and they continued doing this periodically, which was around public engagements. And often we talk about patient engagement, and yes, that's important, but there are some dangers behind that, because we have certain perhaps cohorts of the population who are not represented in that, and we risk going towards quite a skewed perspective from that. So the approach that the YHCR communications team took was a public engagements approach, and they went out into shopping centres, and they took a real mixed methodology of engaging with the public to understand what the sentiment was around the sharing of data and what the concerns were, and looking at how people felt about things like direct care, sharing of data, between health and social care, but also the secondary uses of information as well.
Mm,
So that was really, really important. And I know that there are other parts of the country that have done this. So different shared care records programs have taken a similar approach to that. So I think that's an important thing to mention, because we, of course, were then we understood what people and patients and the public were concerned about, and we could make sure that the engagement materials that we were developing collectively actually helped to address some of those challenges. I think the second part is around it's not just a one-way street in terms of communication. It should be an ongoing collaboration. So often, you might, let's think about, perhaps a survey, or you talk to a group of people, you take that information that they've given you, and then you just, you do something about it, and that's the end of it. Whereas really engagement with the public, especially around such complex areas as this, where the technology is evolving, the political environment is evolving, it needs to be an ongoing dialogue where you're reflecting back what you've heard from the public, what you're doing about it, importantly, the decisions you've made, because of course you can't please everybody or do absolutely everything all at once. So keeping the lines of communication and engagements open. take that right down to the micro level. I think again about some of the excellent work that the YHCR communications team did. They engaged with the public around patient-facing materials. Um, to make sure that the concerns that were identified, and the language that was being used in some of those patient information materials was appropriate, and it was landing with people, and also gave people a clear escalation route if they had concerns. So I think very fondly, back to the pre-COVID days when everyone would jump in their cars and go and deliver training on site. You'd have a cup of tea and a few biscuits. And with you, you would take the patient engagement posters and the patient engagement leaflets as well. And and you'd have materials. We had a communications pack that was made available to GP practices, for example, and that was developed by the central communications function within the YHCR, but we just localized that and we made it available to our local organizations for their patients. But there was also this centralized mechanism where people who had concerns about the use of their data, whether that was for direct care or whether it was for secondary uses, could go through to a centralized person, and somebody who picked up the phone or picked up an email and could have a conversation with members of the public about their concerns. So I think that's really, really important that we continue to evolve this, and we just don't dump information on websites and make it difficult for people to engage with, or make it only appropriate for certain cohorts of society. So that's really, really important.
Yeah,
Um,
because because if you don't do that, I guess then if people aren't engaged properly, they don't understand, they start to worry that we've not been transparent, and then they start to get worried about what's happening.
mm,
And if you don't get that engagement right, it can kind of spiral, and
yes.
that's where the kind of sometimes concerns or
Mm,
noise or challenges or publicity starts to come from, because you didn't get that engagement process right, so
yes,
people generally don't
absolutely.
understand.
Mm,
Yeah.
yeah, yeah. It's really interesting, actually. I mean, one of the other things that we did as part of our program, and I'm sure lots of other shared care records programs have done this as well, is we would go out and also speak to patients and patient engagement groups. So I went along to a few with GP practices, for example, and the number one thing that came back from that was, well, aren't you doing this already? I just assumed you were. So there was this assumption that this data sharing and information sharing was already happening between different parts of the health and care system. The other things that people did feedback. I mean, people have heard of things like GDPR, and the fact that they had rights around how their own data was collected, how it was stored and shared, and they wanted to know about that. Not necessarily. I mean, I don't think I spoke to any individual who wanted to stop that, but they did want to understand how that worked. Um, Particularly as we move towards a world where patients are increasingly, we want to engagement in we want to engage them in how their care is delivered, but in an appropriate way. And there were also concerns around security. People wanted the assurances that the systems that their data were held in, and the sharing between those, had a strong level of security within that. And I know that that was absolutely something that our shared care record, but other shared care records as well, designed with cybersecurity and data sharing absolutely baked in, whether it's from a technical level, or a system and a process and a training level. So they're all of those different aspects of it. And I know we've spoken. There are different models for shared care records, but the approach that was taken with Interweave and the YHCR was very much that federated model, where that we didn't have this sort of big data lake in the middle, a single system. It was perhaps a seeker system, as we might have called it, where the data management and the data is residing within the source system. So whether that's a GP system, whether it's a hospital system, or a local authority system, but the data is pulled through on demand, so that it can be viewed in real time, but it's not actually being stored in a central place. But even where, some, certain information is being stored in a central place, for example, with care plans, that there is robust security around that and adherence to common best practice standards, as well. And then thinking about how people are accessing information as well. So it's not just the security of the system, it's making sure that there were, role-based access,
Mm.
people are seeing the appropriate level of information for their particular role in order for them to do their job. They're getting training about how to use that data as well, particularly if it's a type of data, let's say somebody who's working in adult social care who is now getting access to certain data from a healthcare setting, training not just in how to access a system, but how to use that in an informed, and outcomes focused and safe way. And then importantly, auditing that usage
Mm.
as well. People wanted to see that there was, that we could see and audit who was actually accessing patient information, their information, and that there was a legitimate purpose for doing so.
Indeed, and I guess some of the biggest challenges is around making sure we've got that trust of the
Mm,
population rather than anything to do with technology. Because if we don't have that
absolutely.
trust, it's just it's not gonna get used.
Yeah.
I guess the trust of the professionals as well is a real key
Mm,
point, which we can't overlook. Because actually, you know, when you start to see a little bit of success in some of these programs, as the senior kind of responsible kind of person in charge of delivering this, I start to want more and more and more because I've kind of seen how good it can be, and it's getting those foundations correct, um,
mm,
so that you don't outstretch the ambition. Something that's really important. So,
mm,
whether it's data quality, coding standards, the governance process we've just touched on, security,
mm,
the processes which are kind of really, really important. You know,
mm,
as someone who was delivering this, how did you manage my expectations soundly so that
mm,
I was unable to go and manage
mm,
the expectations of
mm.
partners or our board or whatever? How did you kind of undertake that? Because I'm sure I can be a nightmare at times.
Never, John. So I think it's getting those robust processes in place within the governance, but also making that executable as well, and then proving through the governance and the processes that you have in place that that has been adhered to. So I just, a good example of that might be perhaps the onboarding process for a new organisation to access the shared care record and the approach that would be taken for that. And there are a number of things that you as our SRO would want to see. So first of all, John, always want to know the so what. So why are you joining up this organisation? What difference is it going to make? What are the benefits going to be, both to the organisations involved, but most importantly to the patients, or service users who are receiving care? So that was the number one thing. What are you trying to do, and why are you trying to do that? And all of our projects and use cases would go through that immediate sort of qualification, as it were. Because if it's not ticking the box there, it's not worth doing. Once we'd identified that there was a justifiable and beneficial use case, we would then, start going through an onboarding process. And there were a number of different ways we were doing that. Obviously we were sort of mapping stakeholders, making sure that there was support from within the organisations, that they were able to, to commit the resource, not just to the technology side of things, but to the business change, and the adoption, as well. But thinking specifically, I mean, going back to your question around some of those sort of, the concerns that people might have from a security and a usage perspective, it was also working with organisations to make sure that they had the necessary controls in place. So things like GDPR, things like the cybersecurity toolkit, things like the training, and the adoption, and how you're making systems safely available to users. And actually, this was it's a challenging area. If we think about some of those types of organizations where you've got the most friction in terms of the system and how we operate, so those handoffs between health and social care, but also voluntary care organizations and charities. Some of those organizations are not particularly digitally mature, and I don't mean digitally mature just from a systems perspective. They might not have clinical safety officers, they might not have sort of IG embedded in what they're doing. So a lot of what we were doing is providing the support as well as the assurance with those organisations to help them safely adopt, so that they could have the assurances at their side, but also, as importantly, you could have the assurances from your side that whoever was adopting the shared care record was doing it in a safe, governed and structured way, and there were checks and balances in place about the usage of the system, and also the security of that as well. Because of course your role as SRO is not just to to face off into other organizations in the NHS. You also represent the patients and the population more broadly as well.
Absolutely. Something you have to take very, very, very
Mm,
seriously.
mm,
Um, how much of an issue was siloed thinking across the program at the time?
mm,
Okay.
mm,
So whether it be for NHS England competing priorities, whether it be local competing priorities, whether it be kind of the formation of various new organisations, places, structures, ICBs, whatever, was
mm,
there a risk that actually work became isolated into individual channels? And as we start
mm,
to move into neighbourhood mentalities,
mm,
how do we learn from that and push forward to make sure
mm,
that we look
mm,
broadly across requirements rather than trying to tunnel
mm.
everything into single deliveries?
Yes, yeah. I think that's a really, really good point actually, because the even though patients experience their healthcare and they think about how they flow across their contact with health and care organisations, traditionally the NHS and care is set up at an organisational level. So I think back to when we right at the beginning of the shared care record program, and it was right at the beginning of the Lycra program with the Yorkshire and Humber Care record, and right at the outset, we were looking at the feasibility and whether we could push and share data between organisations. So we started with sharing data between GP practices and with one acute trust to start with. So that's absolutely, I mean, that was very beneficial. There was a very rich set of data that was being shared right at the outset, and but very importantly, even though we were starting with organizations, we also started thinking about a particular pathway, and in this particular case it was around cancer. So that was the first use case that we were focused on. So from that perspective, I think it worked well because we had different stakeholders. We had clinical champions in both of those health settings, and that really supported us with moving forward with that. But the danger of that, because it was, we were looking at the feasibility of sharing data right in those early days of the program. The dangers of that is that if you don't focus on the benefits and what you're trying to achieve, it's very easy then for organizations to turn around and when it comes to their turn and say, actually, this isn't our number one priority. We've got 101 other things we're trying to do with our EPR, with our backlog. We've got all sorts of challenges, and yes, we see this is important, but it's probably not the number one important thing that we're looking to do right now in terms of our priorities. So it very quickly became clear to us that we needed to focus, flip the focus and move away from individual organizations to use cases. So what was going to make the biggest difference in the health and care system, but also where were the pinch points and the gaps and the problems within individual organisations that the shared care record could make a big difference. Because obviously, if you start addressing those through the shared care record, rather than just focusing on, this is a technical project where you're sharing data, it can then move up the priority list in terms of what you're doing. And a really good example of that was the end of life work that we were doing. Because this was a particular pinch point, we found that across the systems, organisations prioritised this as a piece of work because they could see not just the benefits broadly across the system, they could see the benefits to them and their patients, and also to their staff as well, because it addressed some of the problems that they actually had. Benefits was another area where actually this cross system working was particularly challenging, because benefits tend to be identified and owned at an organizational level. So again, if we think about a business case, an organizer, if you're implementing an EPR, you want to go out to procurement for an EPR, you're going to put in place a fairly robust, hopefully, benefits case that you can use to justify the investment that you're going to be taking, and prove the ROI over a number of years for the duration of that contract. But that's owned at an organisational level. The benefits across a shared care record are felt across lots of different parts of the system. And there's lots of dependencies within that. So actually, just the practicalities of identifying where those benefits are at a system level as well as at an organizational level. So it necessitated a different way of thinking, where, yes, we needed to identify where benefits would be realized within individual organizations and then tracked, and then, we could focus on the change to make it happen. But we also needed to look at that system-wide benefit realization. And because there's no natural owner for that, there was an awful lot of stakeholder engagement, collaboration, cajoling, and just ongoing, really broad system-wide engagements to actually get the momentum going on that, and sort of identifying how individual organisations as well as the system would take forward that benefit realisation.
So we can see lots of similar themes coming out through lots of our discussion, which is great. So we're starting to look towards the future, and we've got the single patient record. I think a lot of the ambitions that we've talked about and what we had right at the very start of our program are very similar to the ambitions which have been described and laid out across the single patient record theme. How important is it then that we don't have to start from scratch? Actually, it's not a blank piece of paper, that we we stand on the shoulders of the work that has gone previously. There's been a decade of work pretty much kind of go into this. How it'd be a shame if we have to start again to another 10 years to get back to where we are now. How do we what should we be taking out of our program and moving across into the single patient record?
Yes, I think this is probably the absolute key, because across the country, with the various shared care record programs, there has been such tremendous progress to date. And really, really importantly, benefits are being realised now. So to start again from this would be, I think, a waste of all of the excellent work and the learnings and the benefits that are coming out already. I think about this actually because, we're thinking about the shared care record perhaps as something that's completely new, but already I think we've seen models in certain parts of the country where the approaches that will be or should be taken with the shared care record are working already. So if we take Interweave as a case in point, and I'm talking about that because we worked on the Interweave programme together within Humber and North Yorkshire, but I'm sure that this can be applied in other areas as well. But if you think about Interweave, it first started off as the Yorkshire and Humber Care Record. So we had 3 ICBs who were working together, using the same shared care record, and rolling out in slightly different programs, but within an aligned process. Over time, Interweave started being adopted by other ICBs. And what we saw from that was not just the reuse of the technology, but from a really important perspective, we saw shared programs of work in terms of prioritization of the sorts of use cases and outputs that we wanted to see. We saw lessons learned and sharing in terms of the skills and the capabilities of the people on the ground who were working on these programs. And we, rather than people starting from scratch, we had that real collaborative approach. Now, of course, that worked partly because this was a shared platform, but all of those areas that I've just talked about in terms of the shared experience, the shared ways of working, the lessons learned, not starting from scratch, and sort of shared just resource, I suppose, and expertise. That could equally be applied with the single patient record, even if the technology that is being woven together and integrated, the different shared care records are different. So I think about, for example, when we were doing the end of life EPACS solution, um, that was a different system. We integrated it within the Yorkshire and Humber Care Record in terms of making it available to our different stakeholders. But we also, were learning from that as well, from those different systems and how we approach that. Some of those learnings, and I would argue probably the majority of those were generic and could be applied across any different system. Indeed, after one of the webinars we did after the blueprint that we produced for
Mm.
NHS England, I was contacted by a couple of other shared care record programs to speak to them about the work that we'd done. Now they had different shared care records. They were using a different technology, but the principles behind the approach that we were taking were very useful to them. And it was fed back that they could actually adopt a lot of the processes and ways of working. So, again, I think learning from that, taking that forward, and sharing from the experiences is hugely important, rather than throwing out all of the huge benefits that have been achieved to date and the massive learning and the progress that has been made. There will be challenges. We know from our experience, John, that that the data standards, how important that was. And if we go back again to the foundational pieces, we need to get that right. We've talked, or the single patient record program wants to start with two use cases where you've got a lot of patient flow across different organizations and even different systems, so frailty and maternity, but getting the data right for that, getting the foundations right, so making sure that we're identifying our frail cohort of the population in a standardized way, not just within shared care records but across different shared care records as well. It's hard, but that's absolutely foundational to what we need to achieve.
Yes. So actually, if people come to us and look at what evidence is there that this single patient record may be a success, what we can say is it's not just around how we approached the evidence base, which we can say, sharing stuff works because here's the benefits report. It does this, but also the approach which was taken could be shared across the single patient record as
Absolutely.
well. So not
Yeah.
just about the results, but about the
Mm.
method as well. There were
Yes.
definitely,
Yeah. Mm.
I hadn't always thought about that, but there are definitely echoes there
Mm.
through what we did and what needs to be done now.
Yes. Yes. Yeah, absolutely.
Indeed. Tara, that's been really helpful. Thank you very much. Don't get the opportunity much, so let's just say thanks to some people who've helped along the way, because this isn't a 5-minute project. As I say, it's been running for the best part of 10 years now.
Mm.
So to those who were part of that original Yorkshire Lumber Care Record Lycra team, kind of those visionaries, they kind of set something up new, completely open standards, open approach, open architecture. You kind of set us on a really solid footpath, to kind of program director kind of Lee, who did a great
Yeah.
job of kind of pushing us through that
Mm.
first kind of gateway, and then onwards to kind of the broader Yorkshire Care Record team, which became Interweave, who continue to do an amazing job, to our local Humber North Yorkshire environment, to our first Share Care Record team, who took a couple of seeds and grew an orchard, basically, and to our current team who have continued the fantastic work with fewer resources but continue to see significant benefits, to the Interweave partnership it stands now, who have taken a chance on technology and really helped spread it out, and to those who kind of NHS England who have taken chances on us and seeing those benefits now. There are a lot of people, a lot of organisations who kind of took a lot of trust in us, and hopefully we've not let them down. But to all those people who were involved in this journey, thank you very much. To Tara, thank you very much for your time today.
And thank you, John, for your very inspirational leadership through the entire programme, when myself and the rest of the team in that early iteration, but also your continued leadership alongside, colleagues at the Interweave level, such as Lee Rickles and Ian Clucas as well.
Absolutely. Thanks, Tara.